University, a very senior person in palliative care, and a person who is kind enough to provide considerable and valuable time in India as a teacher, learner, as clinician, to improve the quality of care. So I hope you get a lot of information from here. Dr.
Thank you, Sridevi. I'm going to start with an accent check to see if people understand my accent. So if you don't understand US English, you just raise your hand and tell me to slow down, okay? All right, everybody? Nobody's saying no. Yep. Okay, there's no presentation. So we're starting today. Okay. Today's topic is pain assessment. Pain is what the patient says it is. It is a subjective experience. There's no way to do a pain assessment without engaging with the patient or the patient's family. So I'd like to start by quoting one of my, may I say, guru. 2 years ago, Dr. Raj shared 10 rules about pain. Not all of them are relevant today, but 5 of them are. So I'd like to start with these rules because I think they're very helpful. One is to believe the patient. Pain is what the patient says it is, when they say it is, and we need not to discount the patient's report of pain. We're skipping things that are not relevant to today's talk, and we go on to adherence to treatment. I'll elaborate more about what I've learned over the last 25 years about adherence to treatment. I've been fooled many times thinking that I understand what a patient is taking, but we all need to ask. There are many reasons patients and families are not taking medicines, and they need to find out. Third important rule for today's talk is that all pain has an emotional factor, and you need to take the time to find out what that is. It doesn't matter if I fall on a slippery floor and hurt my knee. I have emotion. I might even have a bad word come out of my mouth. I have emotion that accompanies that pain. Next Raj rule is to review the character of the pain, not assume that you understand what the pain feels like for that patient. And always, there at the very end, number 10, is that we recognize that we cannot solve all pain, but at some point we need to recognize that we need to be with the patient. We can't solve the pain, but we spend time being with the patient. Even if we can't solve the pain, we need to stay at the patient's bedside, shoulder to shoulder, and show support. A second guru. I'm asked to check your understanding about these. What's that? My voice isn't clear. Okay, so can we go back and Manoj, can we go back to the big screen and find out how they're understanding? Dr. Raj asked me to check in and see how people are doing with my American English. Can you understand? Put your hand up if I'm okay. Lydia, your hand isn't up. Are you understanding me? All right. Those of you without your hand up, should I slow down? Okay.
And Pally, the video is switched off.
What's that?
There's no video.
Pallium India video is switched off.
Or it was off.
Generally, people will understand better if they can see the lip movement. So can she be visible during the presentation, during the PowerPoint also?
Okay, let's go back to the list. Thank you, everybody. Just to check. A second mentor of mine is the father of palliative care in North America. Dr. Mount. He is a neurologic surgeon, father of palliative care in North America. His comments speak to me, and I'm going to give you one short story about myself. My mother was in a terrible car accident when I was 7 years old. I lived with her chronic pain for 53 years. You can do the math. Her pain, I did everything I could for all 53 years to take away her pain. It paralyzed our entire family. It paralyzed her. Pain is a terrible thing for a family. And I love his last line, which is, this is no place for amateur night. We must make ourselves the best pain doctors that we can every day. I improve my practice. I improve my practice because of what I do here at Pallium. I improve my practice for what I learned from medical students, residents, and fellows. We must constantly work on improving our work, how we address pain. Okay, that's enough of that. Let's start. Okay, I think I gave you all the riddle number one. What is the most important tool for pain assessment? I brought some tools with me. Here's a hammer, a stethoscope, scissors. Can we open it up so we can hear from people? What's the most important tool for pain assessment? I unmute, and they unmute themselves. Anybody?
I think so. The ears, adaptive ears.
What? I'm sorry, I didn't hear you.
I'm saying the ears are the best tool. You should have the. You should be able to hear to the patient properly and listen to what he or she is saying. And
ears. Your best tool? Okay, good. What other tool? Yes, from Bhutan.
We have two types of pain assessment tools in general. One is verbal and non-verbal, like in communication. So we have in the non-verbal, we have the pain score, the chart, the face, warm Baker pain scale, and then the verbal one is the subjective, like we ask questions and ask the patient experience about the pain.
Excellent.
And then we use the.
Okay, so you're asking them more about their experience of pain. Any other tool?
We may not see.
Oh, okay. Well, I'm being a little silly here. I have a tool. Is this a good tool for pain assessment? Stethoscope. Scissors. Okay, I'll stop being silly. Here's the most important tool. if we don't sit down, we don't take the time to be able to listen to the patient. So sitting down is the most important thing that we can do for a pain assessment. I would say that the best pain assessment is a pain assessment where the patient and family are speaking 70 to 80% of the time, and we're talking 20 to 30% of the time, and most of the time we go, or in Malayalam we go, chitty, chitty, chitty. We speak in a way that encourages other people to talk. And in that talking, we gain more and more assessment factors. Okay. Oh, we have Dr. Sajiv Arora, the founder of Echo Online. Welcome, Dr. Sajiv. Okay, he's online. We'll continue. So I get here first. Go to the presentation.
Go to the presentation. See left.
Okay. Oh. So this mnemonic is frequently used. We all learn it in the textbooks, and then we get to the bedside and we often forget it. Each letter has part of the assessment. P is what makes the pain better, what makes it worse. Q is what the quality of the pain is, whether it's squeezing, burning, sharp, cramping. Radiation is where does it go to. S is S for site or the severity, and T is what the onset is. I have found that frequently with beginning learners in pain, people who are learning pain assessment, they go rigidly through P, Q, R, S, T. And I think they lose the beauty of the patient's narrative or their pain narrative. The best thing to do is ask a question that gets the patient and family started, and then sit back and listen for P. What makes it better? What makes it worse? So again, I'd like you to leave with the message that 80%, 20%. 80% them talking, 20% us talking for clarifying purposes. So again, we ask a open-ended question. My favorite is, tell me about the pain. Unfortunately, in the US, and I've noticed it here too, I say, tell me about the pain, and the patient says 5. And they think they're done. It's important for us to say, I understand that 5 is a number, but pain isn't a number. Pain is your experience. Can you tell us more about the pain that you're having and what impact it has on your life? And specifically, I ask about activities of daily living. Are they able to go to the toilet? Are they able to prepare meals? Are they able to eat meals? Are they going to work? Again, how much this pain has an impact on their lives. Now, everybody's pain scale is different, and it would be important to find out what would be acceptable to different patients. I have met in my state, there are farmers for whom 7 is very acceptable. They just can't accept 10. And I think there's lots of places where people are very stoic, and it would be important to understand what would be important to them. Now, I don't see this in India, but I do in the US. Ask, what do you value most? Do you value clarity of mind, or do you value pain control? And that helps me know how well this patient and their family would accept some sedation or some drowsiness. Now, I know this talk is about pain assessment, but the most radical thing that happened to our team at the University of Iowa last year is we started doing a full management, full symptom assessment. Now, we will send the full Edmonton scale to everybody, but if you look at it, it assesses pain on a 0 to 10 scale, tiredness, nausea, depression, anxiety, sleepiness, appetite, overall well-being, shortness of breath, and then you can develop the scale for something else. What this scale did for our team was ensure that we were consistent about checking all the other symptoms, and we were fooled often that the patient who had a high level of depression, their pain scales, when their depression or sadness was poorly treated, their pain scales were very high. Or if they were anxious, their pain scales were very high. We add up the numbers on the Edmonton Symptoms Management Scale and get a measurement of distress. So it's almost like a distress tool. Our patients in our outpatient clinic frequently have a score in the 40s to 50s, and they see us a couple times, and we see the distress score go down. Not because we're magical in palliative care, though we think we are magical sometimes, but after hearing me when I described how this has revolutionized what we've done in palliative care and at the University of Iowa, and the importance of assessing all symptoms, because many symptoms will amplify pain. And the more you can understand depression, anxiety, constipation, we would not want to miss abdominal pain from constipation. And this tool filled out by a patient and their family and could easily be adapted to other languages. Make sure, I think I mentioned early on that we need to make sure to go through each of the medications, including their vitamins, their alternative medicines. Just this week, we found that patients are taking Ayurvedic preparations that are very similar to the preparations that we use in the US. Most important that we find out what they've been taking, and when they stop taking it, why that would be true. Sometimes people stop taking medications for side effects, sometimes cost. Important that we go through each of the medications and not believe the medication list as it's described. Okay, so here's riddle number 2. I don't know whether audience participation will work. It didn't seem to work the last time too well. So what's the differential? What should be on your thinking when a patient has 10 out of 10 pain that doesn't seem to respond to opiates?
Neuropathic pain?
What's that?
Neuropathic pain.
Neuropathic pain, exactly right. What else? That's very good. Any other thoughts? Lydia?
I just thought we categorize it into things that were cancer related, which could be progression, fractures, increased intracranial tension, then muscle spasm, difficulty in absorption, like intestinal obstruction, that kind. And then go to even non-cancer pain, which could be due to diabetic neuropathy, abscesses somewhere, pressure sores, which could cause pain but which wouldn't be opioid responsive, migraines, And then the opioid pharmacology, which meant, are they dosing correctly? Is the pump in place? Is the needle in place? Is she catheterized? Is there urinary retention? And then the fourth category would be the psychological and spiritual aspects of pain if we are completely unaddressed.
What a very thorough response. Thank you. That was very thoughtful. My answer might be less thoughtful than you, which suggests that next time we'll have you do this lecture. I find 10 out of 10 non-opioid responsive pain to be one of the hardest ones. And I think you're absolutely right that you need to expand your thinking to think about an acute fracture that might be a pathological fracture, an undiagnosed abscess, absolutely. And go ahead. So, my top three are neuropathic pain, and then I often find patients in delirium reporting their pain, sometimes 15 out of 10. They go off scale, but they have difficulty localizing their pain. And then the other patient, which will be seared in my memory forever, is a patient with advanced cervical cancer who had a 2-year-old son, and she clearly recognized that she was going to die before her son even got to kindergarten. She was extremely sad, was pushing the button of her opiate syringe driver, which we call a patient-controlled anesthesia in the States, and clearly was trying to medicate her emotional pain with opioids, and it was not working successfully for her. So I think your brilliant list video should also be added as looking for hidden causes of pain that might not be obvious to us. But I do want you to be, as you're listening to that patient report of pain, to be making sure that you're listening for elements of delirium, emotional components, and neuropathic pain. But then we need to go deeper. I think it's so important to talk to people about how they're coping, what they're using for coping. Some people use their spirituality for coping. Some people use family. Some people have maladaptive behaviors. They might use illegal drugs or alcohol. We rarely ask about how pain is affecting relationships. I think we're often embarrassed to talk about intimacy and sexuality. Patients want to talk about it. Frequently, the barriers are ourselves as clinicians having difficulty asking about sexuality. It would be helpful if we also just asked what the pain has done to their lives and what fear it may have produced. Patients frequently don't share pain or new pain or worsening pain because they are concerned that it means their cancer has come back, their infection is worse, and asking them what kind of meaning they attach to this pain or what anxiety it's producing might have them speak to their fears for the very first time. Probably the most challenging assessment for me is when patients aren't able to speak to me in a meaningful way. Patients with advanced dementia frequently have difficulty communicating their pain. Children who don't have language might also have difficulty communicating what's bothering them. The critically ill in the ICUs, those with intellectual disabilities, and people at the end of life. One of the nursing instructors who is a national leader in the US about pain has authored a position statement that we will send on to you about the assessment of the cognitively impaired. She uses a stepwise approach. always ask the patient themselves if they're in pain. And this might work in any of those nonverbal people because they might be able to write, they might be able to do thumbs up or thumbs down. They might still have the ability to speak to you. So still always for self-report. Then look for possible reasons that the patient might be in pain. A good example we have up on the inpatient unit today is a woman who is speaking constantly but not speaking in any way that's meaningful to us. We worried that she was in pain because of some of the facial expression she had. And we looked to see, is it reasonable for her maybe to be in pain? And sure enough, she had a terrible pressure sore on her heel. And so I think looking for causes of pain is a good second step. Then observing the patient's behavior, and I sent out a tool to all of you, and we'll go through that tool very briefly today. Then going to patients and families, and when in doubt, and again, this is one of the papers that you've got, we can try analgesic paracetamol or low-dose morphine. I think when I was in medical school, we thought the heart rate and the blood pressure and the respiratory rate were good indicators of pain. And this physician statement says do not depend on heart rate, blood pressure, or respiratory rate. And the key for me is to not do something and disappear for 2 weeks or disappear for 24 hours, but rather reassess the patient over and over again over the course of the day or every week if it's an outpatient. Here's a list of nonverbal pain indicators. It would be important to do this both with movement and at rest. This also comes from the University of Iowa College of Nursing. And I think it is self-explanatory. I won't go through it, but it might be a tool that would help people stay focused when a patient is nonverbal, to make sure that we're adequately looking. Now this is the third tier. We're going for self-report, then we're looking for physiologic reasons for pain, and then we're looking for nonverbal indicators. I think this is a helpful tool, and again, it was sent in an email from Dr. Vika. Probably the most important part of our assessment is the listening. But I would say a very crucial part is that we touch the patient, we look for delirium, we look for causes that other people might not have seen. I think your extensive list would require a complete physical exam. I like to assess for delirium with a tool called the CAM ICU, but I also look for impairment with a clock draw, which we just ask a patient to draw a clock in a circle. I look at pupil size, vowel sounds, and assess further the site of pain. I rarely part with a patient on our inpatient side without asking them, what do I need to know most about you to take good care of you? That's the patient dignity question, which has been celebrated by Dr. Churchinov, and a great question to simply find out more about that patient. Pain the patient isn't just a person with pain, and they're not just a patient, so finding out more about them. Or you can ask them what gives their life meaning. And then my favorite thing is to say, what are you famous for? And they go, I'm not famous. And then I said, well, chocolate chip cookies, pie. You can find the Indian versions of what people might be famous for. Patients are frequently famous for how they mow their lawns in Iowa. So you find out something that gives you a flavor of who that patient is. And that's it. That's my talk on it. So I'd like to open it up for questions. I think.
Vidya, are we going for the case discussion, or do we have time for some questions on this highlight?
We can take 10 minutes for the questions, Sridevi. It doesn't matter. Yeah. I have a question from the audience. How about assessing a patient about risk of abuse as a routine for patients who may need strong opioids? Dr. Ann, can you answer that question?
I'm not sure I understand the question. So assessing for abuse?
Yeah, risk of abuse when we are prescribing strong opioids for a patient.
The conversation that I would have in the US is very different than the conversation that we would have here in the land of plenty of opiates. We work very hard to understand how they're using it. We might even count how many pills are left. We might do urine drug screens. I'm not sure in the Indian context that I think those are particularly relevant questions, but I do think looking at how many pills they have would be how many pills they have left might be a very prudent thing to do to make sure that the medications aren't being diverted to other people or being abused by people in the family. But I'm not sure that I'm answering your question the way you want. Is that helpful?
Dr. Rajagopal sir, do you want to comment on this?
I would like to, but Vidya, what do you think? I mean, particularly you have worked with people who have had significant drug use problems. I have a feeling that your comment would be much more valuable than mine.
No, so this is, when we are prescribing opioids, strong opioids to a patient, routinely, how do we assess the few questions we will ask just to check or overrule the abuse? That's a question asked by Dr. Nandini, actually.
Vidya, I was trying to get your answer to that question, really. Because you have worked on a patient population who has had problems of drug use, right?
Some have, sir, yes.
Okay, as anybody else wants to take that question?
Sir, I didn't get you.
No, I am asking, would somebody else like to take that question?
Okay. Would anyone else would like to take the question and answer for that? What would you ask the patient to rule out abuse?
I think it's important to identify patients who are at high risk for abuse. And in the US context, the people who are at highest risk for abuse are people who have abused other drugs. So alcohol, cigarettes is a signal that they might be at risk for abusing opiates. Doesn't mean they will, but it means that we want to have a low index of suspicion. Sadly, another important risk factor is a history of sexual abuse or a family history or a personal history of a mental illness. These are risk factors in the US context. I don't know if they're also risk factors here because opiates have been not as readily available. They are very readily available. We have an epidemic of opiate abuse and deaths, high risk of high mortality in the US. But those are the risks. Those would be the questions if I'm looking for high risk patients for abuse. those would be the questions that might be relevant.
Thank you, Anne. The principles I suppose are the same. In the sense, it may be rare, and we tend to forget rare things, and so it's important for us to remember. And I remember Nandini frequently pointing out that we must take seriously our responsibility to curb inappropriate use. Okay, maybe a few things. In all my quarter century in palliative care, I can remember only 2 patients who had history of drug abuse and who came specifically asking for morphine. Both were doctors who had got hooked to the drink. So, the behavior was obvious. Now, one of them, eventually, he had a malignancy, had to be put on morphine. He did not like it one bit. Oral morphine was no substitute at all for him for his drug problem. He wanted injection and nothing else. So that's on the one hand. One thing that if it's a person with cancer and with a reasonable, if we have a reasonable estimate of life expectancy as being limited, I wouldn't worry much about any question to ask. But if it is somebody with a non-cancer problem, and I'm very unhappy about generalizing non-cancers as of now, but existing guidelines say that opioids should not be a first-line medicine. Now, I think especially the seniors amongst us got into palliative care at a time when we were always told that morphine is safe, we should use it liberally. But we also have to remember that when we are putting a person with a low back ache or a fibromyalgia on opioids, we have to expect a significant risk of addiction. So, but having said that, the problem in generalizing that is if it is somebody with a peripheral vascular disease, for example, something that might require opioids, even as a first line, we may have to consider that. So there are exceptions. Generally, if it's a non-cancer problem, we will think several times before we start opioids. Not only step 3 opioids, any opioids, including tramadol. Now, would I ask questions routinely? Not on the first visit, but on the second visit, any one of us should always take care, find out how many tablets has he really been taking. Has there been a significant unsanctioned dose escalation? I think as a routine, that is the only thing that we need to check, and that generally should take care of the problem. But I'm not here as an expert. You are the expert here on problem with the significant abuse. But before I come back to you, I would like to get the comments from anyone who has been listening. Was I understood? Could you hear me properly?
Thank you, sir. Dr. Sam, do you want to add something to this?
Add anything? I think I would agree with what Dr. Rajagopal has already said. And probably the caution one has to take will be with a person who is already an abuser of those been on treatment for the drug abuse. Otherwise, I think one has to check on the dose prescribed and how it has been monitored by the person or by the caretaker.
Can I ask a question to the group? And then I will try to shut up. If you have a person with a known history of opioid use and the person has a cancer pain, would you start morphine for him? Anybody who has an answer, please raise your hand. Mary,
Madam, please unmute. Everyone has.
please unmute your.
Dr. Mary, can you say?
I feel if a patient has already been on opioids, then nothing else may relieve his pain because he's been on the strongest drug. So I don't think you can give a weaker drug to this person. He will require morphine only. I think so.
Yes.
Thank you. Mayank, do you want to comment on this? Mayank? Mayank, you have to.
We asked Dr. Sanklona whether he has any comment because he.
Hello.
Yeah, Mayank, we can hear you now. Yeah.
Yeah. I would agree with Dr. Mary. What Dr. Mary said, that if a patient is already on a strong opioid or if a patient has history of opioid abuse, I would not be irrational towards that patient or be feared to prescribe morphine to that patient.
Would you, and that in such a situation, we would start the opioid, but we would have a verbal contact with the person about never unsanctioned dose escalations, having to contact if there is a higher dose of etc. A very clear statement and agreement between us.
I agree with both of you that we need to use opiates in people who have used opiates in the past, and we might actually be surprised that they need higher doses than opiate-naive patients. There's no doubt. We have an agreement that is written. I call it a safety agreement about not escalating, about calling us if the pain is not relieved, about not selling. We have to do that in the US. So we do have a written agreement. It might make just as much sense to do a verbal agreement. It is, I call it our safety agreement. It's not punitive in any way. It's not a contract. We call it an agreement, largely to make it safe so that patients don't overdose, which is a real risk for patients with an addiction. So the answer is yes. I agree with you, Raj, always.
Dr. Sanklona deals with a lot of people with drug use problems. Maybe he will have something to offer for us.
Dr. Sanklona, unmute. Yeah. Yeah,
can you hear me, ma'am?
Yeah, we can hear you.
Can
Just talk.
Yes. Me? Hello? Hello?
Speak.
So I have a situation, something like that. We have one patient who has lower end of esophagus, who cannot swallow anything. We prescribed him tramadol and some kind of a tablet, but he cannot swallow. So we gave him a morphine injection. So there is a very high chance of dependency. So how can we help this patient without any, because he cannot swallow oral morphine also. So the only way we can relieve the pain is inject morphine. So in this situation, I'm very, hello?
Speak, Sanklona. Yeah.
Yeah, in this situation, how we'll go ahead with this patient? He cannot swallow any kind of any drug because he has got a tumor in the lower end of esophagus, but he has pain. So how can we help this patient with some other drugs other than injection morphine? This is my question.
He's asking.
I think it's clear.
Should I repeat the question?
Yeah. Yes, please.
Sanjana was asking, he has a patient who has a swallowing difficulty due to the tumor over the esophagus, and so
Yes.
that oral morphine cannot be given, and you have to depend completely on injectable morphine. So how?
This is a patient with a drug use problem.
Yes.
No, that patient, he's 65 years old. He has no drug use problem. But in the past 5 to 10 years ago, he had alcohol problem. That is the only risk he has. Otherwise, he has no other drugs problem. So he is 66 years old. But he cannot swallow even saliva. But he has pain. The only choice we have is injection morphine. But we are afraid of getting abused these drugs. So what to do, sir?
Dr. Sanjana, I think he doesn't, as I understand, he doesn't have any previous history of drug abuse. Then definitely morphine is indicated either in injection form or rectal form.
Yes.
So you don't have to.
We gave him injection from a subcutaneous injection form. We gave him morphine. We are afraid of giving IV, so we gave him a subcutaneous morphine. But we are afraid of getting high and dependency.
I think Dr. Sanjana is concerned about going up high doses, whether it can cause addiction. Was that your concern? Yes, Dr. Madhu.
I'm not sure how much the background noise is irritating. Is it okay to speak?
Yes.
Yes, ma'am.
Okay. So I think even patients with drug abuse have the right to relieve their pain with the precautions. So of course, we need to look at different routes of administration other than oral if patient is not able to swallow. Patches are an option. Per rectal is an option. But the addiction potential, you say that few years ago he had an alcohol abuse problem, which makes the patient a little higher risk than ordinary, so that we need to take precautions. That does not mean that we do not give him analgesia, and even if injections are required, it may have to be given at the stage where because he's in an advanced stage of illness, we should not withhold because of a history of abuse. We need to make our monitoring a little more intensive, and make sure that he has, and also we need to remember he will require higher than the usual dose, because he would have if he has had any history. So the principle behind is, I think every patient, irrespective of whether they have abuse potential or not, requires, they have the right to pain relief. We need to understand how to deal with them. So this patient clearly is a higher risk, and parenteral is not a contraindication. It does not mean that parenteral only gives rise to addiction. All routes of opioids can lead to addiction. It's just that parenteral, especially the intravenous ones, can cause addiction more easily because of the peak plasma levels and the euphoria created. So that oral is not like, it never causes addiction. Dr. Rajgopal was just explaining that all formats can cause. It is more often seen in injectable drug users. So I hope partly I have answered the question.
Thank you.
Thank you, Dr. Nandini. Now we will move on to the case presentation because we are already a little behind the schedule. Is that okay with everyone?
Yeah.
Okay. Sangluna, you have to mute your mic. Sridevi, we'll start with Dr. Jennifer. Dr. Jennifer, you're ready to do the presentation, Dr. Jennifer?
Yes, I'm ready.
Yeah, we can start your presentation now.
Can you hear me okay?
Yes, yeah.
Okay, so I saw a 56-year-old man in an outpatient clinic in Calcutta. He has a cancer of the buccal mucosa. It's diagnosed 2 years ago, and it's a cancer. It's a sort of here, hanging off. He has a kind of large mass coming off his lip, maybe about 3 centimeters by 1 centimeter. Initially, he was recommended to have surgery, but for some reason this didn't happen. He's been seen in our clinic for several months. I've taken over in the last month or so, and the main complaint that he has is pain. It hasn't been effectively managed with the analgesia so far, and we've also been encouraging him to go back to the hospital for definitive treatment. Can we go to the next slide? Okay. So his pain is severe and constant, 10 out of 10, unable to sleep, and it's inside his mouth here and round here. I started him on morphine initially. I'll talk about that later, but I started him on morphine. Now he's been taking morphine. He has a burning sensation in the same area, which possibly might be a neuropathic component. And he also has a lack of appetite for 1 month. So previously he's had these medicines, paracetamol, diclofenac, tramadol, amitriptyline, but none of these really helped. So we started morphine, initially 5 milligrams. After the first week, he had been taking 2 tablets at night to be able to sleep. So he'd been taking SOS dose. His pain has reduced a lot, and he's been increased to 10 milligrams 4 hourly and 20 milligrams at night. And now it's about 2 out of 10 pain score before he starts his next morphine dose. But he also has a lot of psychosocial issues. So after he'd been taking morphine successfully for 1 week, no, 2, he called our social worker and told her that he wanted to end his life. He actually took an overdose of morphine, 10 tablets, and we've seen him since then, and he says he was frustrated about the growth from his lip and his finances. He's having difficulty getting work at the moment. He's still smoking as well when he feels frustrated. He says he's not worried about dying, but he's worried about suffering. And he's not keen to go back to the hospital for treatment because he felt that they didn't treat him very well, and that he was judged because of his financial services. Sorry. So he's married and he has 1 son and 1 daughter, but they both live away from home. His son has been to see him recently, been emotionally supportive but not financially supportive. The patient feels that he's becoming a burden on his wife, and she's had to leave her job to care for him at home, not physically so much as emotionally care for him. And there's also a past history of domestic violence towards his wife several years ago. And in fact, after he took the overdose, he pushed her. When he woke up, he was angry and pushed her, but no other violence recently. So the main concerns are similar to what we've been talking about, that he needs morphine for his pain, but there's a risk of overdose. Also the fact that he has total pain. So he feels more positive now that he has some relief from the pain, but I feel that because he has pain relief, he can now think about all the other problems in his life that he couldn't think about. When he had very bad pain, all he could think about was the pain. And I think there's one more slide. So this is what we did. I don't know if it's the right thing, but we gave him a few days of morphine supply yesterday. His wife has agreed to keep it and give it to him, and he's agreed to this. And he states that he won't take another overdose. they'll pick up another few days after that, and we'll see him in the clinic next week. Also started some amitriptyline for the burning sensation, because this is bothering him quite a lot because it's constant burning sensation. They've agreed to visit the hospital and for possible surgery assessment, and he can call us if he has any worries in the meantime. That's the end of the presentation.
Would you like to put your main concerns and main question to everyone, Dr. Jennifer?
So my main concerns were how to manage his, not just how to manage his physical pain, but how to manage his total pain, all his financial, social, psychological worries. And the other thing is maybe to check whether people would agree with how we've managed it since him taking an overdose. And any advice about that?
Yeah. We have among us Dr. Sam, who is a psychologist. Sir, do you want to comment on this?
Maybe let's see. Let's have a discussion first, and then I'll comment on. Let's see how others.
Okay, sir. Okay, sir. So, anyone else who want to comment on this? Yeah, Dr. Mary?
I think this gentleman requires a lot of psychosocial support. Maybe a counselor can interact with him, and that kind of support is also required, particularly since he has a past history of drug abuse and he may be likely to be on morphine. So I think he requires a lot of counseling also in addition.
That's a good one. Akhil Garg, you put up your hands. Do you want to speak? Dr. Akhil Garg?
Yeah, madam, patient requires psychosocial support. Are you hear me?
Yes, yeah.
Hear me?
Yes, we can hear you.
Yeah. He needs psychosocial supports and proper dose of antidepressant.
You're suggesting antidepressant along with that?
Psychosocial
Psychosocial support and antidepressant was your suggestion,
support,
right?
and counseling. Yeah.
Yeah. Okay. Thank you. Anyone else would like to add something to this? Yes, Sridevi.
Wondering whether we need to address or go much more deeper into the existential suffering. I got from Jennifer's description that he has some pain of existence, like because of the growth, not earning. And just my thought, do we need to go much deeper into the existential suffering?
Smriti, you want to say something?
Yeah, what I want to say is time and time again, it shows that people with head and neck cancers, there is a higher correlation of suicidal ideation and stuff like that. A lot of that has to do with the fact that because it's so disfiguring, it's not a disease that is easily hidden. It's not easily hidden, right? So it's literally in your face. And with that comes a sense of humiliation, with that comes a sense of isolation. All of those things are interrelated. And dignity becomes a big issue here also. I mean, in terms of, if the wound is, if it's smelling, if it's something that that's bothering the patient in terms of just managing. Also, what I would like to what I would do is try and explore the dynamic between the husband and wife a little bit more. She is his main source of support. There is a history of domestic violence, and I would try and support him through her, because she's also the main caregiver. I feel that if she is adequately supported also, that will take us a long way. Jennifer, you said that he's looking for a job and he gets turned away because of the way he looks. So does that mean that he is, apart from his disfigurement, apart from that, is he mobile? Is he energetic? I mean, is he able to work in that sense?
He physically is able to work. He just, because he feels, I'm not sure if it's definitely true, or if it's his perception, but he feels that he's not getting work because of the growth. It's not an ulcerating growth. It's like it almost looks like a kind of cutaneous horn that you get with skin cancer coming from his mouth. But we also, I've spoke, my interpreter lives locally. We were thinking about putting him in contact with some people that could offer him work. So that might be something that will help him feel like he has a purpose and that he can achieve something.
Okay, I think that's a really good avenue that you're going down. But I'd also think of the wife as being a high risk. At high risk for self-harm at this point. That's just a feeling I get. Devtita, we did I think we also talked about assessment of suicide risk, and it wouldn't do us any harm to also do that sort of assessment with his wife. I think that's something that can be done just to assess the risk on that front. And maybe, look at that. So that's my suggestion, just offhand.
Yeah, I think that's a good idea.
Vidya, you raised your hands. Do you want to say something?
No, I just wanted to know if there is no option for any disease modifying therapy, any local radiation or anything that would work to bring down that, or is it financially impossible for him to do it, or has everything stopped completely on that front? Then maybe it will improve his body image, or if there is anything else that we can do to help. I'm unsure if he doesn't have the resources, or is it not possible? That is what I want. In addition to his psychosocial issues.
So we have talked to him a lot about going back to the hospital, because I feel that then he will get some reassessment, because it's actually been, I think, more than a year since he initially went to the hospital and they recommended surgical management. So he needs reassessment, and we've tried to explore why he doesn't want to go back. It seems that he feels there was an attitude from the doctors. It is about money, but not just about money. So we've now come to the position that he will go back to a government hospital, possibly not the same one, with his wife, and see what they say for reassessment. I think he now understands a bit more that if he can get treatment, it might change his outlook.
Yeah, Vidya.
Thanks. That's just what, because if that would do, I think it would help him. And now that his pain is controlled, it's probably a good time to address. And if we could have a volunteer who could accompany him or help him that way, I'm just thinking aloud. Thanks so much.
I think one of the things that was also an issue is that he's been treated for so long without being given analgesia that has helped. So he's been coming to the clinic on and off for, I think, 7 months maybe, and every time given small amounts of different painkillers, but it's not been that continuous. Whether it's because he didn't come back to the clinic, or I think it's possibly because he didn't come back to the clinic regularly, but now one good thing is that he is coming back to the clinic regularly. He's been maybe 3-4 times to see me now, so at least maybe he has some trust and he thinks that we can achieve something, maybe.
I think when Jennifer was presenting, I thought the priority of concern was first was suicidal thought and second was the pain. I think it may have to be reversed as Dr. Vidya was suggesting. Focus on the pain and see what can be done to reduce the pain from different modes of treatment. That might be the reason for him to think of ending his life or taking off his life. But if that has been addressed, then as Smriti was suggesting, I would think in terms of assessing the risk for suicide, if that is your concern at the moment. So you also mentioned that the patient has expressed the desire to take life to the social worker. So the social worker or the person who is communicating need to assess the risk or how seriously the person is thinking about suicide. Because in your report, you also said that the person is not worried about death, but he wants to end his life. Maybe he wants to get rid of the pain. So how seriously he is thinking about suicide is the person to be done. And as if I remember, I'm not able to remember the name, one of the speakers was suggesting about the possibility of assessing depression. So if you assess the intensity of the suicide ideation, then you also see whether there is any associated depression coming in. Because in your report, you have already said that there is a problem with the sleep, and for the past 1 month, the person is not able to eat well. These are definitely signs of depression. But again, I am just wondering because the person has not responded well, though he was on admitted care. So that's what's making me whether you have to reassess the depression and think of it. If the depression is intense, then you may have to look at different kind of antidepressants and see whether that would relieve him of the depression. Of course, the counseling part will be the support has to be given from different levels. We also said that the son has moved away from him. That could be another issue which I think Sridevi was suggesting about the existential things that are coming up. Those are all that can be that has been dealt with if you are taking him further for the counseling sessions. Maybe at this stage, if possible, more frequent sessions may be needed.
Yeah, may I speak? Again,
Yes, sir.
if everybody has already given their input, I have a few comments about several other comments of starting with Mary. I know you are working in an institution where you have access to counselors, which is great. You recognize the need for counseling. But one of the negatives in having good counselors available is that we ourselves tend to shift that duty completely to them, so that we do not get the expertise needed. Maybe I would also suggest that yes, send him to a counselor or get a counselor to see him, but also let us think about how we would handle that ourselves. And Akhil said psychosocial support, absolutely, thank you. But what is the psychosocial support that you are going to use? I mean, we have to be specific. And as Dr. Manikam said, if we are giving antidepressants, that would be after assessing whether it's a clinical depression that is causing him the problem or an existential issue. Like the man asking, what's the point of me being healthy? My children do not want me. They don't care for me. I mean, this wife, okay, she's caring for me, but she's angry with me because I used to beat her up. There was domestic violence, right? There's a pattern there. Here is a man who now simply does not feel loved. The treatment has to give him love. I mean, we, the palliative care people, are the only people who can possibly be non-judgmental. His wife is caring for him, but somewhere inside her, she would still have the feeling, likely to have the feeling, this is a man who used to beat me. We can be non-judgmental. With our eyes, face, and body like this, we have to convey to him, we care for him. I mean, we would be counting the tablets, etc., yes, but the message is be careful. And of course, make him talk. It's important for when this is a person who requires extra time, Jennifer. He needs to tell his life story. We need to pick out a few points that you can admire in his strength. Maybe the way he combated life. Maybe he has had a hard life himself. Something that we can admire. I mean, when you convey to him that I really admire that in you, that would restore a bit of the dignity that Smriti was talking about. Totally left alone, no body image, horrible, rejected by every employer. Naturally, there's nothing to live for, but your respect gives him dignity. And Smriti, oh, thank you. And I had forgotten that as we were talking about him. Thank you for remembering the wife. Here is a woman who is suffering. And maybe I would tend to go and tell her, okay, give him love or something. That would be wrong. We need to listen to her and find out her problems. And Vidya Vishwanatha, you put your comment right on the top. Before dealing with any issue, we will think of disease-specific treatment, definitive treatment. Palliative care should not result in denying disease-specific treatment. Sorry for the long lecture.
Thank you, sir. Jennifer, do you want to ask any more questions, or can we move on to the next case presentation?
Yeah, I think that's been really useful. We are going to be in more regular contact with him, and we'll try and assess it a bit more next week. The other thing,
we have called his wife also for assessing her independently, her psychological issues. We have to know more about her part also, and we are also going to in a regular touch with the patient also. And we have the patient is a very good in electrical parts repairing, so we have started searching some jobs for him in the local area so that we can earn from.
But I think next time particularly I will assess more his suicide, well yes, but also his suicide risk and whether it is any depression. I think initially I felt if we treated his pain he would feel better, but that maybe was a little bit too simple. So I think I need to clinically assess him for depression as well. But I hope that we are providing him some support by him coming every week. But thank you, it's been very helpful.
Yeah. Thank you, Jennifer, and thank you, sir. We will be sending a reference article regarding assessment of suicidal thoughts as well, so that may be of some help to you. Because we are running out of time, I'm moving on to the next case presentation, which will be Dr. Mary's case presentation now. Dr. Mary, you're ready to go? Yeah.
Once again, good afternoon to everybody. This is a little girl, a a 13-year-old girl who's actually a neighbor who lives in my own colony. And I've been involved with her ever since the illness started because they are very good friends of ours. She's a 13-year-old girl who was diagnosed to have acute lymphoblastic leukemia in February 2015. And she was, because they had some good contact in AIMS, she underwent chemotherapy in AIMS. And subsequently, she went into remission. And then after sometime in July in 2016, she started going to school along with her normal activities. So she basically went into remission. The doctors were very happy. And she went into remission and she started a normal school and normal life. And she continued to be on maintenance chemotherapy. However, in November 2016, she had a relapse and she presented with bleeding in the oral cavity with severe bone pain. That was her presenting features this last November. And the bone pain actually started in her left wrist, and then later it spread to both iliac bones. It was acutely progressive, the pain, and the VAS became, the visual analog scale score became around 10 over a period of 4 to 5 days. She was admitted in AIMS, and she was started on opioid infusion. But that did not relieve her pain. She says it hardly relieved 20 to 25%, that's it. But then they started her once again on induction chemotherapy, and after 4 to 5 days, the pain gradually subsided, after which she was started on, she was given a fentanyl patch and paracetamol, and she was also given pregabalin. And she was discharged. In December 2, that is the next month, she developed fever, breathlessness, and cough, and she was diagnosed to have fungal pneumonia. She was admitted and started on antifungal and systemic antibiotics. And after about 10 days, she was discharged again and chemo was restarted. In January 2016, she had a recurrence of fungal pneumonia, again admitted, received treatment for the same, and again discharged in about 3 to 4 days. 1 week later, she had seizures and altered sensorium at home. We rushed her to hospital, AIMS, and there the CT revealed a ring in enhancing space-occupying lesion in the right occipital lobe. And this was confirmed with MRI subsequently, and the diagnosis was possibly a fungal abscess, or they kept the possibility of tubercular abscess also in mind. She was started on anti-epileptic, antifungal, anti-tubercular drugs, and steroids, as well as continued with her maintenance chemotherapy, and she was discharged after 3 days. Now her problem since January 3rd week is that she's having a burning pain and peeling of skin in both soles. This pain is there throughout the day, but it is worse at night. It is very severe. She says her pain score is around 8 to 9, She cannot sleep the whole night. Her parents are all the time having to massage her feet, apply borolene, calamine, and things like that. It is not associated with numbness, tingling, or weakness. The difficulty she has is while only because her soles are painful, she's having difficulty in walking and keeping her sole on the ground. Otherwise, she has no difficulty in walking. Her sleep is affected because of the pain. And like I said, there's some relief with calamine lotion. But the oncologist actually had stopped pregabalin, and he felt this was a reaction to cytarabine. And so he stopped that drug immediately, and next slide, please. Okay, and he put her on cetirizine. On assessment, this is a normally built 52 kg child, conscious and oriented, no pallor, vital signs were stable. General examination and systemic examination is within normal limits. The central nervous system examination revealed no sensory or motor deficits, nor was there any reflexes were all normal. Local examination showed peeling and redness of the skin in patches on the soles of both feet. There is no dysesthesia, hyposthesia, hyperalgesia, or allodynia. Her PPS score is 70. Next slide. This is a picture that was taken 2 days ago, and in which I don't know how clear it is, but there is peeling, and there is mainly in the lateral aspects you can see the redness in the soles and also along thenar and hypothenar eminences. Next slide, please. The treatment. For bone pain, when she was admitted in November 2016, she received IV morphine infusion along with round-the-clock intravenous paracetamol, around 6 hourly. The pain subsided only after 4 to 5 days despite morphine infusion. And when it subsided, she was put on fentanyl patch, which was gradually tapered off, and along with tablet paracetamol, she was discharged. She continued to be on an induction chemotherapy for the relapse of ALL. For burning soles, which started in January 2017, she was on pregabalin, but the doctor stopped it and he recommended only cetirizine after stopping the cytarabine. But at present, we have restarted her on pregabalin 75 mg/Hs. It started only since 2 days. She continues to be on a maintenance chemotherapy, on antifungal, antitubercular, anti-epileptic therapy, as well as steroids. Next. The psychosocial spiritual history. She's an intelligent and cheerful girl, except when she's in pain. She cannot bear pain, needles, injection, because she's gone through a lot of trauma in the last 2 years. During her illness, she remained a very positive child, yearning to go to school and interacting with friends. She's receptive to advice from her elders. She has good family support. Mother is a child counselor in school, and she's a professional child counselor. And her parents are the anchors in her life. And they are very positive and always keep inculcating positivity in this child. She has faith in God and she believes that she will become well and go back to school. Family history, no history of any family illness. Father is a lawyer. Mother is a child counselor in a school. She has a younger brother, age 10. Next. So the main concerns are, the present concern is severe burning pain in both soles associated with peeling of skin. It has very, very little it has responded to pregabalin, because even today morning, her father said that again in the night, they were up the whole night, just massaging her leg and applying the calamine. So it has not really improved. And because of that, she cannot sleep properly. She's had now a relapse of ALL, and she's now planned for a bone marrow transplant. She also has a space-occupying lesion in the right occipital lobe, which is most probably fungal, although she's also on ATT. So at the moment, she's getting antifungal, antitubercular, anti-epileptic therapy, steroids, as well as maintenance chemotherapy. Next. So the questions that I want to sort of get from the answers which I would like to get is, the severe bone pain that is associated with the relapse of leukemia. Opioids obviously were not very effective till only when the chemotherapy started off did, I think, the pain subside. But even morphine and paracetamol were not effective. The second is the present pain, which is a burning pain and the peeling of skin. It's most probably due to chemotherapy-associated peripheral neuropathy. Or is it an allergy to cytarabine, as the oncologist suspected, because he started out on cetirizine and he said to stop all the pregabalin. How do you manage it if it is a neuropathy due to chemotherapy? Is there any role of antidepressants? And is there any role of duloxetine in cytarabine-induced neuropathy? So these are the questions I'd like to get clear, because the child is still having pain, so we need to address that. Thank you.
Yeah. We have a couple of questions from the audience, Dr. Mary. Did the burning pain and skin changes appear simultaneously, or which was prior first?
It started off with the peeling of the skin.
Peeling of the skin.
And then the redness appeared, and then the pain. And I forgot to mention one thing. The sole feels very warm on touch.
Warm on touch. Okay.
Very warm on touch, yeah.
How about pulse?
The father was telling her to put her leg in a tub of water also, so it feels warm. But it started off with peeling.
Peeling, okay.
Yeah.
How about pulse in the pulse? Pulse.
Pulses are well felt, and there is no allodynia. There is no sensory changes at all.
Okay.
And the power is good.
That's good. How about any NSAIDs are used?
Nothing. They are only on paracetamol and.
Thank you.
She's only on paracetamol and pregabalin, and even the fentanyl has been stopped.
That's good.
Patch.
Yeah. Now we'll open the discussion for the whole floor. Yeah. Any comments on this? Vidya, you want to say something?
One question. Have they tried using lignocaine gel on the feet?
No, they haven't. In fact, that is something which I want to now. I thought of it as an option. Like, what about capsaicin or lignocaine gel? They have not tried it, but I think that is one of the options I was also contemplating. But it has not been recommended by the team in AIMS.
Yeah,
It's also being looked after by the pain clinic at AIMS. AIMS, they have a pain clinic, the IRCH. So they also didn't recommend it, but I was considering using a lignocaine gel or cream or something like that.
Because it kind of works. I don't know that's a question, whether how much evidence base we have for this. They have lidocaine patches, but looking at the like how neuropathic it is, or vincristine-induced neuropathy, we do use duloxetine. But this thing, I just thought applying lignocaine gel, because it kind of works in our patients when they have this zoster pain, like post-neuropathy. So I really don't know. That's my question too. Do we have any evidence for this, and how do?
And in this respect, what about capsaicin? Capsaicin ointment.
One more question. I do not know. Maybe the others would. An IV lignocaine trial. I mean, they do it, but that's again guarded in a hospital setting, a prior ECG and all that. But this is just my question.
IV lignocaine would help more with neuralgic pains, right? I don't know about neuropathic pain.
I'd leave it open to the others to answer, because I really don't. But
Mayank,
something I would have kind of tried.
yeah, Mayank wants to say something. Can Mayank speak?
I think that the main concern of, as I can make it from Dr. Mary's presentation, was how to manage pain in this child.
Yes, the burning pain.
She's having a pain of 8 or 9 out of 10 on a VAS score and associated with burning sensations. Yeah. So according to me, I would like to start the patient on morphine, oral morphine, along with anti-neuropathic medication. The choice would be to start with amitriptyline, because the patient has burning sort of a pain. Usually it has burning sort of a pain is mediated by C fibers, and the antidepressants have a better role in management of C-mediated fibers as compared to a neuralgic form of pain that you said. So I would like to start the patient on tablet morphine associated with NSAIDs and amitriptyline. Of course, with laxatives and antiemetics. And as Dr. Vidya had said, that what is the evidence for lignocaine gel? I don't know about the lignocaine gel, but definitely the IV lignocaine has got its evidence for neuropathic pain. Yeah, that's it.
Yeah, thank you, Dr. Mike. Mary, do you want to say something?
See, the thing is, actually, since she's taking treatment from AIMS, I don't want to really interfere, because even the parents know me so well, they look up to me for everything. But even I know what's the Lakshman Rekha when I'm concerned, because they ultimately will go by what the oncologists and the doctors there say. So I can only suggest to them, but they would be sort of yeah, that's it. So I'm also a little guarded in my recommendations.
Yeah. Why did we think it is neuropathic pain?
Because it is burning in nature. It is very, the burning pain is generally neuropathic.
Yes, it is. And do you think
with redness? So that's it.
Okay. Is it spontaneous kind of pain, or?
Yeah, it is present all through the day, but worse at night, all throughout the day.
Okay. Mayank, you wanted to say something?
Yeah, Dr. Vidya was asking about talking about lidocaine patches. I don't think so. They are available in India. And regarding capsaicin, We also have another, now the gabapentin is coming in a gel form, that is gabamexla. I don't know whether it is available elsewhere or not, but it is available and it is helping in our patients with neuropathic pain. We have not yet tried it for cancer-mediated neuropathic pain. We have used it for non-cancer-mediated neuropathic pain, and it is showing results, of course, with other oral medications. For example, we have used it with post-herpetic neuralgia. So it has shown good results.
What is the name of the drug?
It's gabapentin, which is available in a gel form known as gabamexla.
Okay. That will be interesting to know the name of that.
Sir, would you like to say something on this topic, sir? Dr. Rajagopal, sir.
This is Ann Broderick, sir, but one of the thorniest, most difficult pain syndromes we're treating is chemotherapy-induced neuropathy. We have not found it successful to use lidocaine patches, lidocaine gel, gabapentin, pregabalin. None of these have worked very successfully. Duloxetine does have the indication for chemotherapy-induced neuropathic pain. I don't know, is Abhishek still on the line? I don't know if he is or not, but he may have seen a demonstration of scrambler therapy, which is promoted by a group at Johns Hopkins and the Mayo Clinic. They describe scrambler therapy as TENS unit on steroids. It has shown some efficacy in clinical trials for chemotherapy-induced chemotherapy-induced neuropathy. For me, I don't know that drug, Mary, well enough to know if that is a culprit for chemotherapy-induced neuropathy. But if it is, it would be perhaps worthwhile seeing if duloxetine is indicated in children. I don't know that. That might be my first line before going to other therapy. The scrambler is not available. It's still in clinical trials at Johns Hopkins, which, but is, I don't know what to do with the peeling and the redness. That surprises me a little bit because normally there are no physical findings in chemotherapy-induced chemical.
So, can I say something?
Yep.
So, I think cytarabine is a cancer drug that is known to cause like a hand and foot syndrome. So the peeling and all of the pain may actually be, like the oncologist suggested, due solely to the cytarabine, and as it continues to work out of your system, the lesions may heal up completely on their own. It doesn't come to mind as one that's commonly known to cause peripheral neuropathy. And she's so young and hasn't gotten that many cycles overall of chemo that I'm not as high as, I don't have as high of index of suspicion as it being a true peripheral neuropathy. And like Dr. Ann was saying, typically you don't see the actual like physical skin changes, the peeling and redness with the peripheral neuropathy. It's more just the sensation of burning or pins and needles or prickling type of pain. So it would be interesting, how long has she been off of the cytarabine?
Can you repeat the question, please?
How long has she been off of the cytarabine chemotherapy drug that the oncologist?
It was started in December.
And then when did he stop it?
This started only in the last week of January.
Okay.
Maybe time.
And they say that it takes that long, 1 to 2 weeks for the toxicity to appear.
Yeah, and I've seen it take over a month to heal up. Yeah. And sometimes people still have like scars or almost bruises from where the hand and foot kind of sores were, the peeling. It can take a long time to recover from.
Can I say a word, please? the trial with duloxetine, I think that people were over the age of 20 years. I don't know whether it's recommended in anyone less than that. There is a trial which showed that the duloxetine was effective in cytarabine. But what I'm worried about is it really chemotherapy-induced neuropathy? Because she doesn't have any other findings other than the pain and burning. There are no other neuropathic features. So that is why, whether it is...
I have a question. I don't know if I misunderstood. For this pain, opioids have not been tried, right? Is he still not getting the fentanyl?
No. Fentanyl has been stopped, yeah. She's not on anything except for pregabalin. That's it.
I think I'm wondering if we are not trying something very easy. Even if it's neuropathic pain, I do consider another possibility here, a vascular pain. Because in leukemia, not including the bone pain that the boy has had, could be because of microvascular occlusion, as happens in leukemia. And the hyperemia that you see on the foot makes me suspect obstruction of venules again. So that is a possibility, in which case, along with the ischemic pain, there would be associated neuropathic pain. Even if it is also, there is I suspect an ischemic component of the pain. And even if it's neuropathic pain, opioids would still be more than trial. So maybe going something as basic as that is something that I would consider. Capsaicin, remember, in a substantial number of people, capsaicin causes initial severe burning. So we can actually make the child both with capsaicin. So a trial, if at all tried, should be on a small part of the lesion, and capsaicin is not the wonder drug that takes care of all pains. And lignocaine, it's a 10% patch. Would be, I should think that it would be possible to apply it over the patch to be applied over the toes. If the toes are in pain, generally you need to cover a whole surface with that. I thought Nandini's hand was going.
Dr. Nandini.
Yeah, when I first, I was just going through the sheet of Dr. Mary. I thought I saw only night pains. Patient wakes up at night due to pain. So I thought there was no pain in the day. And just like Dr. Rajgopal, even I first considered ischemic pain as a reason, because it's typical for a leukemic patient to have the gravity assisted flow to the leg during the day, and at night when they become recumbent, the pain comes up, and typically the arch of the foot and the ball of the the toes start hurting a lot with severe pain, and the child wakes up. That's a typical history, and that is a burning pain because there is a vasa nervosa being affected. So one thing, Mary, you can definitely try is that ask the family to position the child for 1 or 2 nights with the legs dangling and see if the child is more comfortable. That's a simple intervention we can try. And if that is helping, then we can definitely consider this an ischemic component. Thank you.
How about role of pyridoxine in this patient, ma'am?
Yes, it's possible. It's mentioned on chemotherapy.com.
Yeah, role of pyridoxine, yeah.
I'm just using a resource that's called chemocare.com that I use that helps to look up side effects of chemotherapy drugs, and followed a link to hand and foot syndrome or palmar-plantar erythrodysesthesia. And they do mention, but without much of an explanation, that taking vitamin B6 or pyroxidine may be beneficial in treating this. But that would be something that the oncologist should be more familiar with as well. It does also mention that rubbing lotion on the palms or soles should be avoided because it can increase friction and that can actually increase the pain. So the thought is that the sores develop because following administration of chemo, the small amounts of the drug leak out in the very small blood vessels in the palms and soles. And so ongoing friction can actually cause kind of increased leak of the drug. And that's when you get the redness and the tenderness and possibly peeling. And I have seen it that it can do just the palms of the hands, just the soles of the feet, or both.
Thank you, Susan. Dr. Mary, you want to say something?
My question is it really a chemotherapy-induced neuropathy? First of all, that is a question.
It can be.
I think the answer from cancer, what is it?
Chemocare.com.
Chemocare.com is that you have a side effect of the medicine, and patience and not rubbing the feet is the right solution.
Potentially, like cold packs could help. Something cold that she could set her feet on, that may help. But it sounds like rubbing them might actually make things a little worse.
What about the medications? Do we continue pregabalin? And like Dr. Rajgopal said, we restart her on opioids.
Not sure. I'm not sure if it's opioid responsive.
You said that it's self-limiting, no? It will disappear.
Mom, tell that to the child.
Right.
Ask the child to wait for. I mean, I believe that in neuropathic pain, that doesn't easily get corrected with something else. I believe that an opioid trial should be. I mean, opioid trial doesn't take a week. It takes something that takes hours. You take it for a day and see, and if it doesn't seem to work, you withdraw.
Thank you. Thank you so much.
We will also be sending some reference articles, Dr. Mary, for you to read about.
Thanks. Thanks a lot. Thank you.
Any other questions to be asked regarding this case, or shall we move on to the next case? I think we missed out on bone pain. What do you think? Have we addressed the bone pain at all? Dr. Mary?
Not really, but because it was not effective. Morphine was not effective for the bone pain. It was only when the chemotherapy, the induction drug started off, and maybe I feel that must have, sort of controlled the blast cells or whatever it's there in the bone marrow. That was the only thing that ultimately, along with the morphine, of course, but morphine per se was not effective in her. It hardly gave her 25% relief. So what do you do for this acute bone pain because of a relapse of leukemia? What is the best drug that you can give?
Dr. Iqbal, do you want to say something? Can you unmute? Unmute yourself. Yeah, speak now. We are not able to hear you. Iqbal, we are not able to hear you. Okay. Sir, you wanted to say something?
To Iqbal that we cannot hear.
In case of thrombocytopenia, what is the ideal drug to use, sir?
The question is specifically to me. In thrombocytopenia, the only objection I can see is to NSAIDs other than paracetamol. That is, already the count is low, so any little platelet inhibition of platelet adhesion can cause a remarkable clearance. So I can't think of any other analgesic being objectionable in that situation.
How about COX-2 inhibitors, sir?
I clearly, they would be clearly objectionable because that's a group of drugs that we know increases the tendency for microthrombin. And in a patient like this, with leukemia, with already a problem of potential microvascular obstruction, where we suspect that the pain could be due to that. No.
Thank you, sir. We'll move on to the next case presentation. I think, Sridevi, you are ready with the next presentation for Farzana? Farzana, you ready? Yeah, we'll move on. Farzana, you have to unmute yourself. Yeah.
Good afternoon, everyone. I would like to start greetings to convey my greetings to Professor Ann, Dr. Mary, and Dr. Jennifer, and also to Sir and everybody because of fascinating presentations and because I could learn many things while I was listening to their lectures and the discussions. So this patient, she was a 38-year-old lady diagnosed with metastatic adenocarcinoma in both of her ovary. It may be called a Krukenberg's tumor. The tumor was metastatized, disseminated hugely to the peritoneum, omentum, and local lymph nodes, according to actually this case history was sent to me from Center for Palliative Care. One of my colleagues, he sent it to me. Actually, he wanted to present this case, but unfortunately, he has to go to outside Dhaka today. That's why I am presenting the case. So this patient, Mrs. C, she was a household worker, and she went to Saudi Arabia 5 years back, and there 3 months back she became sick and with abdominal pain, vomiting, and loss of appetite. She tried a few treatment but didn't feel well, so she decided to return back to Bangladesh, and ultimately she ultrasonogram and all the other investigations revealed that she had adnexal mass and moderate ascites and ultimately metastatic adenocarcinoma. So surgery had been done before 3 months, and 2 cycles of chemotherapy was given to her, and on the 3rd chemotherapy, planned chemotherapy, she was referred to the Center for Palliative Care of Bangabandhu Sheikh Mujib Medical University due to severe pain and vomiting. So I would say Center for Palliative Care is the only one center, tertiary level center in Bangladesh, where patients are treated and all kinds of home care, indoor, outdoor, and telephone care. All treatments are available in Center for Palliative Care. So this patient has intractable vomiting for more than 1 month. The vomiting was intense, 15 to 20 times per day, and foul smelling, undigested food particles, and fecal matters also were present with the vomiting. And she had pain more than 3 months, and she described pain, 3 kinds of pain. like severe pain, which started around the umbilicus and radiated to whole abdomen, and it was cramping and throbbing in nature. And this pain actually started with vomiting. Whenever she vomited, then this pain started, and this pain was severe, 8 to 10, according to VAS scale. And she had another sustained, persistent pain, which was, and Dr. Rubaiyat said me that the abdomen of this patient was very rigid, and everywhere there were abdominal mates. So she had whole abdominal pain, and that was excruciating, and always she had a 10 out of 10 pain. And above all, she had also burning sensation to her lower abdomen, low back, and both of her upper thigh. So, and this pain was also severe, rated according to VAS scale 7 out of 10. And she, while presenting to the CPC, she had absolute constipation for more than 1 week, and she had restlessness, sleep, and also sleeplessness. Next. And they followed her up. At first, they treated her as an outpatient, and after 1 month, she was admitted into the Center for Palliative Care, and she was treated with injection morphine, tablet amitriptyline, injection oradexon, and they also tried gabapentin and other things also. Finally, what happened? Her all other complaints except pain were relieved. Her constipation and vomiting, all other symptoms were relieved except pain. Pain was not relieved, a bit reduced, but not at all relieved. And next, please. And this patient was from a poor family, and when she was returned back from Saudi Arabia, she used to live with her mother, brother, sometimes with her in-laws also. And her husband died 10 years back, and she had 2 daughters. One daughter, 19 years old, and she's married. And the next is 12 years old. She's a student of class 7. And she was actually depressed and sad always. And she always thinks that what will happen to her family and her daughters. And all these thoughts made her anxious. And as her husband was not there, she was mostly anxious about her second daughter, what will happen to her. And her mother also grew old, so she thought that her mother won't be able to take care of her second daughter many times. So she was really upset. And but spiritually, she had full faith in Allah, and although she was confused why she had given this type of disease, because she heard that there is no cure of this disease, and but why she has given this disease, and she felt that she might be guilty of something else. She might have done some sin. That's why she had given this disease. And the whole family is suffering with her. This was some of her thoughts. I have already told the family history. And she had no family history of malignancy. And the patient died. She was admitted on 16th January to the Center for Palliative Care and died on 29th January. So what I could find out that the team could reduce her nociceptive pain but the neuropathic pain persisted till her death. And other symptoms were controlled, as I said earlier. But so I want to ask two things: that how to manage this type of intestinal obstruction, pain, and other issues at the end of life. Because I think intestinal obstruction is difficult to manage. Intestinal obstruction due to malignancy is difficult to manage, and other things. I had talked to 4 clinicians in that center about what they asked, what was the communication at the last week of her, the clinician and the patient. So they told me that they didn't talk to the patient because they were afraid of discussing all these things to the patient. But they talked to her sister and brother and others. But I think people's goals are changes with time, because this patient may have other goals other than dying in the hospital. So I asked them, did you ask what are the biggest fear or concerns of this patient? They said no. And what goals were important to her? Did you ask them? Then they said no. Same cause was related to same, that they were afraid of asking the patient. And I was really eager to know what were most important to her, and what were the things she was willing to do, and what were the things she was not willing to do. Because most of the time, what I can see, and I think you also can see, that in the end of life, in our Asian countries, most of the thing we concentrate on the physical pain or physical issues. We just cannot think about the psychosocial issues. Sometimes we elicit these things with history, but most of the time we don't actually do anything with these issues. And I want to ask you, what are the things we can do more easily? Thank you.
So anyone want to comment on this? Yeah, Dr. Sam. Yeah.
You have answered your question at the end. You said that we are not looking into other issues other than the clinical condition. I think that's I felt that, I don't know what you have done, but that is very important in some cases. End of life, giving the kind of support or being with the person at that moment to see what the concerns are is very important. We might feel that the person has got a strong faith, has a strong belief, but at the same time, what are the issues or concerns that are arising out of that? For example, you have already mentioned that whether she is responsible for some of the issues that has come up. Now, that discussion on those issues might help the person to relieve pain from an emotional or spiritual side, because the physical pain may continue. So I was just thinking, maybe along with the physical treatment, this issue also may have to be more important. Sometimes, we ourselves are not comfortable in listening to them. That might make one person introspect. Where am I with this person in my own life, that might help the person to relate better with another person.
That it's important to aggressively manage physical symptoms as soon as possible, because it's very hard to talk about other issues when someone is in severe pain or vomiting 15 to 20 times a day. That's all her whole focus, that becomes your whole world. And so to, like I said, very aggressively, in the same way that you would if someone was admitted to an ICU and struggling to breathe, you would go to that person, put all of your attention on them to get them feeling as best as possible, as soon as possible, so that then these other issues, these other things about life reflection, that they can come out then. But if you don't aggressively treat the horrible pain and the horrible vomiting, it's so hard to have those other discussions. But we can do it. You just have to kind of, and you gain trust that way too, that you show we were able to help you with these symptoms. And then that sometimes opens up to a whole nother conversation, and we can help relieve other suffering that way.
Farzana, any comments on this? Unmute.
Yeah, thank you. That's really true. But this could be a total pain also. We don't know because the pain didn't relieve at the last part of just on 29th she died, and 29th morning she died. On 28th night, at night also she had 10 out of 10 pain. So it's they increased the dose but didn't help her. So it could be total pain. That's my thought actually. Thank you.
I just wanted to look at the medications. Because too much of constipating drugs were going together. Was it because she had some colic with the motility drugs? Because she was on morphine, she was on isobutyl bromide without any attempt to relieve the obstruction, or has it been done already and failed and then started with blood paralysis? I just wanted to review the medications.
Farzana, unmute. Farzana, unmute.
Yes, Bidda, can you please show the follow-up slide, treatment slide? That's there actually.
Yes. Yes, Farzana.
Yes, morphine trial started, then injection hyoscine butyl bromide and omeprazole sedil was given on admission, and increased injection morphine dose, and more 3 rescue doses were needed, and tablet amitriptyline injection Orodaxan and NG tube for continuous suction. So they tried to relieve the obstruction things, and after she could sleep after pain relief. And pain relief was the first to pain. I mentioned that she had 3 kinds of pain. The neuropathic or burning sensation pain could not, she had no relief at all. And the other pain were relieved. And injection, then again injection morphine doses were increased gradually, and injection ketamine was added, and she could not tolerate ketamine, and injection ketorolac 8 hourly they added, and injection ondansetron 8 milligram IV every 8 hourly, and injection haloperidol also. So although he did not mention any laxative, but I think they had
constipation. Was there?
I think because it is in the chart of Center for Palliative Care. Whenever patient is given morphine, so laxatives are given. Maybe he forgot to mention in this one. Thank you.
But also the obstruction, whether it was partial or it was complete, I think that there's a problem with the assessment itself right from the beginning because the details are not clear. The detailed assessment of the symptoms.
I think the one major drug that may be missing would be Dexona. Could have been used as well to think of it as decreasing like gut wall edema, and sometimes that helps with pain control and sometimes even opens up the obstruction. So that would have been one other medication that I would have tried.
So is that
Dexamethasone was added.
Yeah, it was added.
Auradexone. You mean Auradexone was dexamethasone, but it was being given along with hyacinth butyl bromide, not with any. So I think that shows some factors. Because what we want to achieve with the dexamethasone is to relieve the edema, and if it is a partial obstruction, then you want to make space so that everything will move on. But you are giving dexamethasone, the tumor edema has reduced, but you are given something which makes the gut completely silent. So what was the plan to achieve? I'm not clear about those medications.
You have some anti-motility drugs. You have ondansetron, morphine, hyacinth. So 3 drugs that would slow motility. So even if the Dexona decreased edema, you need something to push, right? We need either a laxative or metoclopramide if it's a partial obstruction. So I think maybe we don't have all the details, but it would be helpful to have something that would increase motility. And Dexona. Dexona.
Farzana, was flatus passed? Is one question from the audience.
Yes, flatus passed, and even small stool also passed afterwards. Yeah.
Okay. Yeah, Dr. Maya.
Dr. Fazana, when you said that you started on injection ketamine 0.5 milligram orally, I'm not sure that whether that is the right dose for orally or not. So you said patient did not tolerated it. So what exactly the patient manifested with? Am I audible, Dr. Vidya?
Some
Actually,
description is there. Yeah.
Because someone sent me this, I have to talk with them. The real details, actually, all these details, I don't know. Yeah, whatever. Thank you. Yes.
Maybe we'll continue that question maybe in the next session so that we can clarify that doubt. Thank you. Dr. Anne, you were about to say something. Can you continue with that?
No, I realized, Dr. Farzana, that we didn't recognize Floradaxone. That's probably dexamethasone. Is that right? Okay.
It is. Next time we should be using just the pharmacological name rather than any of the brand names. So it's easy for everyone to recognize. Thank you. Farzana, do you still have any query to ask regarding this patient?
No, for physical pain and physical issues, I don't have any query because I know there are so much to do. But this kind of patient at the end of life is actually very we struggle to reduce their sufferings. But what I was talking that the team, they don't know how to what to ask and how to talk to the patient about these things like a prognosis, and we have to start. So I want to ask Professor N, how can we do that? What are the easy steps to start talking direct to the patient, not through the relatives? Thank you. Because at the end of life, we can apply the dignity therapy, and how to achieve that. That is my one of the questions.
The dignity question is the one to start with. I think you asked all the right questions. What gives her life meaning? What would make me for a peaceful death for her? Asking those questions would be profound, and it would allow your palliative care team to address the issues of her two daughters. Clearly, her biggest concern was the outcome in the lives of her two daughters. I think giving voice to that is probably the most important thing that we can do, and we need to do it sitting down. I'm going to go back to my refrain of sitting down and being relaxed and able to hear that. We think most interventions are pharmaceutical, and it just turns out that sitting and touching is most meaningful. I'm struck here at Pallium that many times I can't speak directly to patients. I need to try to speak to an interpreter, but they can feel compassion in all sorts of ways that's not verbal.
Thank you so much. Yeah.
Very meaningful case. I do think ovarian cancer, she has a very high tumor burden, and I think you did exactly as I would. Thank you for that. I think.
Thank you, Farzana. And thank you, Dr. Ann. We have another 10 minutes to go. I want to bring up the question of last time when we did the case presentation, we came up with some recommendation and we shared with everyone. Yeah, Vidya, you want to say something?
Just one moment. In the light of this conversation, I just thought it would be nice if we had guidelines on how we use medications, the combination, if we could create it, and especially because octreotide is expensive for us. And another thing is dealing with intestinal obstruction along with a colostomy and use of high enema, all these things, if we could nicely compile guidelines, we have so many of us, and such big names here. So, and if we could have this in all our palliative care centers, it would be great. So that's just.
Thank you, Vidya. I will send it as a homework to everyone. Once everyone sends their comments, I will, compile it into a guideline and send it back to everyone. Is that okay with everyone?
Yes, ma'am.
Yeah, thank you.
We like that, Vidya.
Yeah. Coming back to the review of the case, I think only Dr. Iqbal and Bill Sheba I can see. Did the recommendations help you? Can you comment on how do you feel about that? Dr. Iqbal is not there? Bill Sheba? Okay. Iqbal, I think the audio, there is a problem. How about you, Bill Sheba? Or Sandra from that center? Can you unmute and talk?
Very helpful.
Yep. Can you come again? We are not able to hear.
Yeah, Sister Bill Sheba is not here, but yeah, the overall session was very helpful.
Not about this session. It was the previous session I was talking about. She did a case presentation. That's okay.
Yes.
We'll get a feedback from her then.
Okay.
Yeah, thank you. Anyone wants to ask a general question or any suggestion from your side, please raise your hand so that we can discuss about that. Nope. Mayank?
Nothing, ma'am. It was great. Can we have?
Yeah, tell me. Mayank?
Nothing. I was expected to be relieved 10 minutes earlier.
Okay. Dr. Nandini, you're there? No. So we'll end this session and I will, yeah. Nandini, do you want to say something?
No, I think so many of the questions are pending in the sense, Vidya Vishwanath has raised some things. In each case, probably, I know we don't have time, but we could put that up and maybe we should really work on this suggestion and make the Indian possibilities for malignant obstruction, bowel obstruction, then, the unanswered questions regarding the bone pain and like that, we'll see the 3 cases and we will continue the discussion after the echo, between this echo and the next. I think very good participation from all the participants. I thank everyone.
Thank you, ma'am. Thank you. Dr. Mary, you want to say something?
I just wanted to say that this is an excellent learning experience, and I think very, very well coordinated between all the concerned people, and I'm really enjoying it. That's all. I think it's a wonderful experience, excellent talks, excellent lectures, and it's a great learning experience. Yeah.
So we will leave the meeting now, where I will follow it up with the email. Anything we have left out, kindly get back to us so that we can address to that. Thank you, Dr. Anne, for the presentation. And thank you, Dr. Jennifer, Mary, and Farzana for the case histories. Thank you very much. Bye.
Thank you.
And don't forget to send cases for next week.
Thanks. Bye.
For February 17th, we are back.